Okay, great. Welcome, everyone. Good afternoon. Buenas tardes. It's my pleasure to introduce Dr. Camille Chaffee. She does her research focusing on improving health and substance use outcomes among people with substance use disorders. She's a lived experience researcher with a particular focus on highly stigmatized populations, including houselessness and people who inject drugs. She earned her doctorate in June 2020. She's currently leading a JEEP initiative funded by NIDA, which is the Justice and Emerging Adult Populations, and focusing on postpartum mothers. She's currently co-leading two RADx Up initiatives. That's the rapid acceleration of diagnostics for SARS-CoV-2 testing in underserved populations. That's not to mention a third project, which she took a lot of leadership on, which was the Latinx community testing. She's leading an intervention pilot project on the CPOP50, which she will be presenting today. I had the great pleasure of working with her on this. She brought her skills as a substance use researcher to help translate our evidence-based program, Fathering Through Change, for single and divorced fathers. And the fathers who use substances is even more stigmatized and vulnerable than divorced fathers. And one of my passions is understanding what we can do to improve the lives of families for fathers who make independent contributions of biological mothers, and also for their own benefit and well-being in connecting with their children. So excited to hear our results today from Camille. Since she earned her doctorate in 2020, she has over 20 peer-reviewed publications. And in just the past 2 years, she's first author in Drug and Alcohol Dependence Reports, Frontiers in Psychology, Journal of Prevention and Health Promotion, Journal of Substance Use Treatment, and Public Health Reports. This is a Google Scholars quick search on the number of citations from 2019 to already, we haven't even finished January in 2023. And I would call Camille a rising academic influencer based on her early productivity, how she manages a family life, multiple projects, and conducting all her commitments and leadership at the center is very inspiring. So very pleased to introduce Camille today. And one announcement, housekeeping, for those of you who would like CME continuing medical education credits, there will be a survey at the end. Once again, it's my pleasure to introduce Camille.
Well, thank you so much, Dave, for that extremely generous introduction. I am so honestly privileged that you are my mentor, and I just really appreciate you, and wish I could just do the same presentation for you, but that then we would not have time for this presentation. So I'm excited to talk with you all today about our findings from a randomized controlled trial to improve fathering among fathers with substance use disorders, which we call the Fathering and Recovery Intervention. And also just want to acknowledge our team who made this work possible, including Anastasia Browning, Sven Halverson, Lauren Ball, as well as our clinical team who provided some of the coaching for this. I also want to acknowledge that we have a clinical trials registration number, and that this the research reported in this presentation was supported by the National Institute on Drug Abuse under the award number that you see there. And I also just want to give a huge thank you to our community partners, including Serenity Lane, Willamette Family, Integrated Behavioral Health, Reddit moderators, and all of the dads who participated in our research. And today I hope to spam you with all sorts of cute dad pictures while I give my presentation. There were actually just so many to choose from on the stock photos, and I hope you appreciate them as much as I do. So I want to start by giving a little bit of information about fathering in context. So in the context of substance use disorder and what that really means and looks like. And it's going to be brief. There's so much more to talk about here. And I'm happy to share other citations of Dave and I's work to give you more context if you're interested in that in the future. But essentially, the biggest thing that I want you to know is that quality father involvement across contexts and father residency status has been associated with benefits for children. So what that means is that no matter if you live with your child or spend only small amounts of time with your child, whether you're affected by substance use disorder or under-resourced economically, quality father involvement still matters and can still and is helpful for children. So dads matter. Fathers may also be the only parent available depending on context associated with substance use. For example, while we're dealing with the opioid crisis, overdose deaths are rising, as well as other issues around child welfare. We know that sometimes dads are the ones raising their children. However, research with fathers is limited. Most research that we have is focused on the mother-child relationship, and that's important too. And we need research with fathers as well. We also know that fathers living with opioid use disorder and substance use disorder in general are at high risk for incarceration, family disruptions, health problems, and financial hardship. Which means that they're dealing with a lot of different things in addition to their parenting and a lot of structures or systems that they're beholden to, which just makes life and the ability to find time to engage in parenting supports harder, and finding supports that are really tailored to their unique circumstances more difficult as well. We also know that fathers experience greater substance use severity and risk behaviors compared to mothers, and are more likely to be misusing opioids when they first become a parent. Additionally, fathering in the context of substance use is associated with lower parent self-efficacy and sometimes fewer positive parenting behaviors, such as consistency and father involvement. We also know that psychopathology can confound or complicate or cause both substance use and negative parenting behaviors, as well as fewer positive parenting behaviors. So I just want to make that note to say that it's not necessarily about substance use alone, and that mental health challenges can really complicate things for fathers, and that they are in need of that support as well. We also know that father substance use disorder can be transmitted intergenerationally, so from father to offspring through gene and environmental influences. And those are usually manifested or seen phenotypically as child behavior problems. And so intervening early to try to prevent or lessen any child behavior problems that we're seeing can also disrupt the potential intergenerational transmission of substance use disorder. So that's a little bit about fathering in context. And I'm going to talk to you about a theory called social interaction learning theory, which is this theory that we are basing our intervention on. Essentially, social interaction learning theory describes how the family social environment shapes patterns of child behavior. And it suggests that parent-child interaction patterns provide the behavioral reinforcement for the child's likelihood of engaging in future prosocial or antisocial behaviors, so otherwise kind of thought of as behavioral challenges. In addition to immediate improvements in child behavior, teaching skills can help parents feel more confident in their parenting and increase positive parenting behaviors. So teaching skills that essentially reinforce positive behaviors and do not reinforce less desirable behaviors. Additionally, there's some evidence that improvements in father affiliation with their role as a parent through increased confidence or self-efficacy, as I mentioned before, is another term for confidence, may improve their overall well-being, including potential reductions in substance use. So what does this look like in practice in terms of reinforcing behavior and social interaction learning theory? So one sort of classic example is a child requesting candy in the grocery store. And when a parent says no to a child's request, the child might, throw a tantrum in the middle of the store. In fact, I read a book called Llama Llama Mad at Mama. I don't know if anybody's familiar to my toddler, and that's exactly what happens in the book, is that the child is throwing a tantrum in the store because they're frustrated. The parent might say no to the child's request, and then the child might throw this tantrum, and the parent might reward them with candy. So we don't think of it as a reward, we're thinking of it as a way to stop the behavior, but the parent is essentially rewarding the behavior by providing candy in order to get that negative behavior to stop. So again, the child learns in that interaction that if they scream for the candy, that they will get the candy. And so some parents might also use things like hitting, yelling, and harsh punitive discipline to extinguish an aversive child behavior, like asking for the candy in the grocery store when a child misbehaves. And while this discipline does work in the short run, a child can learn that coercion among family members can be used to stop other behaviors of family members. So what we're teaching them is basically the behavior that we're modeling. So conversely, a strategy to reinforce desirable behavior in line with social interaction learning theory would be for a parent to state expectations prior to going into the grocery store by saying something like, today we have a list of groceries and I need your help getting everything on our list and nothing else. And they might scaffold this to provide a token as an incentive for each item the child helps a parent get, or kind of provide incentives broadly that are agreed upon in advance. So again, it's looking for opportunities to reinforce those desirable behaviors rather than the ones that we don't want to see. So this parent training model for social towards the, in line with social interaction learning theory, focuses on teaching parents effective parenting practices. And by teaching parents effective parenting practices and family management strategies that control reinforcing contingencies. So we also think of contingency management related to substance use disorders and that being effective. So basically, if this happens, then this positive thing occurs. Fathers can reshape patterns to promote healthy child development and also grow in their confidence as a parent and have more positive relationships with their children. Essentially, this is operant conditioning. And so fathers are learning to contingently reinforce pro-social behaviors and use non-coercive strategies and consistent pro-social limit setting to extinguish antisocial behaviors. So the specific aims of our study were to establish the feasibility, acceptability, and promise of evidence for the fathering and recovery intervention, improving fathering self-efficacy and parenting practices. We hypothesized that the intervention would improve parenting self-efficacy and parenting practices relative to the control condition among fathers in recovery from substance use disorders. We also wanted to understand whether the intervention could reduce the likelihood of future substance use for the fathers themselves and improve child behavior. We hypothesized that there would be secondary benefits of the intervention specific to these pieces, substance use and child behavior specifically, while accounting for psychopathology. We randomized 41 fathers who identified as in recovery, anywhere between 1 day to 18 months in recovery, to either the intervention or control condition. They were recruited from substance use disorder treatment facilities and social media. Fathers in both conditions completed surveys at baseline, 6 weeks, and 4 months. And fathers in the intervention, fathering and recovery condition received content delivered by text messaged videos each week for 6 weeks. They also received $5 incentives for each knowledge quiz they completed after watching a video. And they also received up to 3 coaching calls to problem solve strategies that were introduced in the videos. And some of the strategies introduced in the videos, including how to set clear expectations. We talk about timeout and what that looks like and how it's effective. We also talk about praising desirable behavior, token systems for rewards to reinforce positive behavior. Some of the other things that are mentioned in the video that aren't quite social interaction learning theory, but are contextually relevant include how to protect children from conflict with a co-parent who might not be living with you, and also just how to engage in active listening to build relationships with your children. Fathers in the control condition received online materials about parenting and recovery. And at the end of the 6 weeks, we also sent them the videos or at the end of the 4 months, excuse me, we also sent them the videos so that they had access to them if they'd like. So our measures during this clinical trial were the parenting practices interview, which has skills for harsh, inept, and pro-social parenting. And is a 35 item scale rated on a 7-point scale, and higher scores in each subscale indicate greater frequency of the behavior. I won't go too far down each of these, but if you have questions about the constructs at the end of the presentation, I'm happy to answer them in more detail. We also, for self-efficacy, used what we call the TOPSY, otherwise known as the tool to measure parent self-efficacy. And that is on an 11-point scale, where 0 is completely disagree and 10 is completely agree. And some of the items are, I'm able to have fun with my child. I can plan activities that my child will enjoy. Playing with my child comes easily to me. And some others as well. We also assessed intervention knowledge for people in both conditions, which included items that were tailored specifically to the ideas that we were teaching in the videos, and higher scores on intervention knowledge indicated greater intervention knowledge. We measured substance use using a measure developed for the Center on Parenting and Opioids, and that included past 30-day use, both as a frequency item, so the number of, or the relative proportion in the past 30 days that a father indicated use of alcohol, cannabis, heroin, methamphetamine, cocaine, and other drugs other than nicotine, as well as a yes or no for past 30-day substance use. So both as a count variable and as a dichotomous, essentially abstinent or non-abstinent. We measured child behavior using the SDQ, which stands for Strengths and Difficulty Questionnaire, and essentially higher scores on the SDQ indicated greater child behavioral challenges. These are, in terms of our results, starting with acceptability and usability, fathers rated their experience of the fathering and recovery intervention as high in acceptability. You can see on a 1 to 5 scale, the mean was about 4.55 at the 6-week time point for fathers in the intervention, and 4.49 for fathers who completed their 4-month survey. They also rated that their experiences were high in usefulness, so they felt that what was provided in the intervention was useful to them. And at 6 weeks, the average was 4.63, and at 4 months, it was 4.34. And some of the open-ended qualitative questions I found interesting. So fathers liked the accessibility of the videos, the accessibility of it, and how easy it was to get advice through the coaching calls and also the videos themselves. They shared that I liked that it focused on my situation. I liked the easy explanations. I liked how they showed what good looks like and what bad looks like. And that participant is describing that the videos provide an example of an effective parenting behavior and also parenting behavior that was ineffective and then reinforced the effective behavior. Fathers wanted, in terms of changes, fathers wanted longer and more videos, which is actually not typical feedback that we get from video-based interventions. I think usually we hear that they want shorter videos. They also said that they wanted more coaching calls they felt like the scenarios could be more realistic. This was an adaptation of a intervention that was originally designed for divorced fathers. And so there were not specific adaptations made for this population other than some slight reordering of the videos. They also suggested that we should use different actors, which they said should be a bit more rough. And I assume that to mean maybe less put together looking in the way that the actors were in the videos. Related to the coaching, they shared that they liked that the coaches weren't pushy or judgmental, and they felt they were very encouraging and gave good advice and wanted more coaching calls if possible and more at their convenience. And now to the statistical effects that we saw. So we, for the parenting outcomes, we assessed those at the 6-week follow-up and the 4-month follow-up. These are the results for the 6-week follow-up. And we used linear models to compute these regression equations. There were no baseline differences between there were baseline differences between conditions on psychopathology, which we accounted for in the analyses, as you can see here, as well as inpatient, people receiving inpatient treatment. And so we accounted for both of those things because of the baseline differences. We see here that there was a significant effect on improvements in intervention knowledge, but there were also significant changes in terms of decreases in inept parenting, as well as improvements in pro-social parenting. While it wasn't significant, there was also an increase in the expected direction on parent self-efficacy, and there was no change in harsh parenting. At the 4-month follow-up, we saw that the effects on intervention knowledge were not fully maintained, but were still in the expected direction, that parenting self-efficacy improved and inept parenting remained improved. There were still no differences in harsh parenting, and the effects on pro-social parenting were not maintained, but were still in the expected direction. I should have also mentioned that we accounted for baseline scores as well in these models, which you can see are highly predictive of the follow-up outcomes, and accounted for those in all of our models. The 4-month follow-up, we also assessed child behavior challenges and father substance use. And as you can see here, at the 4-month follow-up, child behavior challenges were not significantly changed, but were in the expected direction. Substance use in the past 30 days as a count variable was also in the expected direction. And abstinence in the past 30 days as a dichotomous outcome was more likely in the intervention condition as well. In terms of our discussion, so overall, we demonstrated the feasibility of remote delivery through high satisfaction and usability. We characterized the potential relative advantage of including coaching calls as opposed to standalone video content. And we also found that there were no clear adverse effects of the intervention, and the effects were aligned with the expectations, though not always statistically significant. We also saw that there were clear differences in inept parenting and substance use, which are important given the population. So essentially what we're seeing from my perspective is that there's no, and I should have mentioned before as well, that this parenting intervention was derived from the Parent Management Training Oregon, which is an intervention that's been around for a long time. It's based in social interaction learning theory, and the tenets of the Parent Management Training Oregon model include adaptation. It traditionally was delivered as a group-based or individual-based intervention that was more person-to-person. So this adaptation for video for fathers was novel in and of itself. For fathers, it's been adapted for military families, and it's also been adapted, as I previously mentioned, and Dave mentioned as well, for the fathering through change intervention, which was for divorced and separated fathers. This intervention essentially took the the group of videos that we had. And at first we were considering whether we should deliver the intervention in person, and COVID sort of made that decision for us, because when we started this project, it was really right at the beginning of the pandemic. And so what we ended up doing was preparing to deliver virtually, which is how we decided on the 6 weeks of text messaged content. And I think given this long background in parent management training Oregon and a series of efficacy trials for various populations, what this data shows us from my perspective is that there's no reason to withhold the intervention from fathers in recovery just because we haven't had a large scale efficacy trial. Now that said, we of course do have some limitations. Oh, and Dave also messaged me to say that the reductions in child problem behaviors actually is significant, but that the asterisk in the table was missing. So we also we were just updating some of our findings for this presentation. So we also do see changes in child behavior, which is also obviously an important finding and something that we were hypothesizing would happen. So in terms of limitations that we need to note. So our sample size was really small. It was an N of 41. Of course, we lost some dads to attrition at different time points. We were able to, even some of the dads that we had lost at the 6 week follow-up, we were able to re-recruit them for the 4-month follow-up, but we still had some missing data. Because this is a small sample, it does require validation in larger studies to truly determine efficacy within this population. Next, parent management training interventions have been effective for many groups, as I stated before. Our pilot supports that there's no clear reason to withhold the intervention from this group of fathers. So we're not seeing any ioterogenic effects or, in other words, any negative or harmful effects for these dads. In terms of future directions, from my perspective, as somebody who prefers doing community-based research, I really think that we need to understand the real-world implementation considerations that specify under which conditions the intervention is most successful and for whom. So not just seeing, under these sort of research optimal conditions, does this work? Can we understand more clearly, do we need the coaching calls for this to be effective? What's the exact number of coaching calls that makes this most effective? Who's more likely to engage? Who's not as likely to engage? And how do we engage them? What are some things that we can do to better engage people who are maybe more hesitant or don't have the technology or the resources or have other structural limitations that prevent them from fully realizing the benefits of the intervention? Additionally, I think that, there's more work to be done in terms of understanding the heterogeneity of the population, understanding, do dads need to even be in recovery to see the benefits of this intervention? Could they be people who aren't quite ready to stop using substances yet? And could we deliver the intervention virtually to them in those scenarios? And of course, in terms of our outcomes, we looked at substance use as just the frequency of use, as well as abstinence. And we know there's so much more to substance use than that. And there's more to understanding ways to reduce risk around substance use in terms of it as a secondary outcome. I'm gonna go to the next slide if that will let me go. So in conclusion, as I mentioned, our study was a small randomized controlled trial pilot, which requires additional larger studies for confidence in our findings. All the results were in the expected direction, clarifying that there were no harms associated with the parent management training for fathers in recovery, and only positive benefits were identified. And the lack of large-scale efficacy testing should not prohibit the implementation or advancements in progress for getting PM2 interventions to fathers in recovery who could greatly benefit from their delivery, at least from my perspective. Here's some more pictures, cute pictures of dads with their kids. And I wrapped up pretty early, but it was a pilot, so we have pretty straightforward results. And here are a couple of cute pictures of the dads in recovery in my life that motivate me to do this work. You'll see my husband on the left getting his nails painted by my daughter, and my dad with my son. Are there any questions? I know we have a small group, and that's all I have.
Nicely done, Camille.
Yeah.
I'm curious, of course, we've talked off and on over the years, and we'll talk again offline about next steps. What settings do you think would be the next logical step in conducting a randomized trial on a larger scale for this program? What do you think?
Yeah, that's a great question. And I see Jake Spavins from Willamette Family also asked a similar question. And Jake, I'm so glad that you're here. Thanks for coming. So our next steps, I think, are to conduct a larger scale trial, as Dave alluded to. And what that looks like, I think, is something we're still trying to understand. I think my hope, so typically the National Institutes of Health has something called the STAGE model, where there is stage 0 is basic research, which is some of the work that honestly Dave has been doing for many years, related to just understanding what are the drivers of parenting and substance use, et cetera, within this population. And then they move to the next stage, which is efficacy trials. So establishing efficacy, which is essentially, does the intervention work in a basic way to improve the intended outcomes in a research setting. And then we typically move to effectiveness, which tests the intervention in more real world settings. And again, with a larger scale design. And then we usually move to the implementation stage, which is where we look at different implementation factors and vary those factors and randomize them between participants and see what works best for whom and in which conditions. So as I've said in this presentation, and what we know is that that sort of pipeline can take 17 years. There's a published number, it's kind of an old statistic now, but it says it can take 17 years for research to move into practice. And we also know that we have, in Oregon, we have a huge addiction crisis. In general, we have higher and higher rates of overdose deaths as well. And so if we have an intervention that can improve both fathering and substance use, or at least holds promise for improving those things, like waiting so long to get it into the hands of people who could benefit, doesn't seem appropriate from my perspective. So I would love to see a large scale study, maybe looking at some of those implementation factors, but it's hard to know if a funder would be open to that. And seeing if we can really get this intervention into the hands of people through that trial as well. And I think that pragmatic studies are helpful for getting it into the hands of community-based participants, because I've seen in interactions with community members, sometimes it doesn't feel aligned with the work that they're doing to involve their participants in something that's randomized. And so how can we meet the community where they're at and find strategies to implement together? Yeah, and I see that Dawn has a question in the chat as well, and says that he's happy to hear about, or that they're happy to hear about research focused specifically on dads, and that this is going to continue, and wants to share, or wants to learn more about the token system because they currently coach a parenting class. I wish I could pull up a video so that you could see the token system, because I think that Essentially, I think that it varies depending on the child and the skills that they need to learn, but it's the one that is taught in the videos is pretty straightforward. It's pretty basic, just and can function sort of like a sticker chart where you have different things that are you could have, if it's a younger child and they're working towards like one thing that's small, that might be easier for them to kind of relate to, versus an older child. You might have different things that are worth different tokens that they can trade their tokens in for, or it could be a different kind of reward, like maybe you go out for ice cream on the weekend or something like that, or have a family movie night. So I think it really, when I was teaching kindergarten, I had this kiddo that had some challenging behaviors, and I called a graduate student. I had just finished my undergrad who had more experience than I did with interventions, and I said, what can I do with this behavior? And she said, well, give them what they want. And I thought that was in terms of the behavior that I mentioned, or the behavior that I mentioned earlier, thinking about like what's meaningful to the child, and how to reward that behavior with what's meaningful to them. Dave, do you have more to add? Because I would love for you to add more.
Yeah, I love that question because it speaks to the heart of the social interaction learning theory and the parent management training model from OSLC, which is very behavioral, operant conditioning. And we actually break down, when we do that, token systems and incentive charts. Token systems are a little more proximal and immediate in time. Incentive systems, and of course, Camille, you were a kindergarten teacher. It can be, marbles in a jar. It can be a chart you put on your refrigerator, and they can earn certain points along the week, and then they get a reward for that set of points at the end. We try not to do punitive approaches. We don't take points away. You don't take marbles out of the jar. And we teach parents how to carry around kid bucks with them, or little tokens in their pocket. And when you make a clear, effective request and a child is compliant, that you give them a token right away, and then you reinforce that. And just, related to this question too, was the finding that there wasn't movement on harsh parenting. We found movement on that in the larger randomized trial, 400 dads online. We've done it, replicated it in several studies for at-risk populations when they get the actual PMTO training, which is 12 weeks to 14 weeks, depending on group or individualized. In changing course of interactions in punitive harsh discipline really takes a lot of troubleshooting and feedback and reinforcement of the principles. And it's actually two thorough sessions in terms of curriculum, and every other concept is 1 week. So that's something I think that we need to expand on. But positive reinforcement, token systems, those are things that are readily implemented. And we believe from the clinical evidence that you have to change the positive stuff. You have to use the positive skills first if you're going to change the course of negative stuff.
Thanks for adding that, Dave. I think that piece about not taking away rewards is really important, and can definitely be an easy sort of pitfall to fall into with parents. I also think that I wanted to note that I know we're talking about parenting and kids, but we know that works for adults too. Like, contingency management is one of the only efficacious treatments for methamphetamine stimulant use disorder. Of course, we give adults money instead of tokens typically, but there are some programs that actually do use token systems in that way as well. So just wanted to throw that out too. And contingency management has also been effective for COVID testing and some other work that I do, again, with adults. Yes, agree. Positive behavior reinforcement is very important. Thanks, Dawn. Are there any additional questions? Great. Well, Ashley has put out the piece for continuing education units. But if you have any additional questions or just want to chat or check in, feel free to hang out at the end of the webinar, and Ashley can stop the recording and promote you to panelist as well. And please, yeah, make sure to vote. This is how you can get your continuing medical education, and that can be used, as Dave, I think, mentioned, for a range of different types of professionals. And you'll get a certificate. They send them out on a quarterly basis, so it will happen right after this webinar, but could take a couple of months, just an FYI. So thank you all so much for joining tonight or today.